Guys, welcome to this previous year question discussion as far as FMGE exams are concerned. Let's start with the first question. A patient with glaucoma also suffering from bronchial asthma. So this is a patient who have been diagnosed as point number 1, glaucoma and bronchial asthma. Which of the following anti-glaucoma drugs should be avoided in this patient? So this is purely to say we are going to be talking regarding drug interaction and contraindication of a drug. That's what the question is. Let's look at the options. We have timolol, we have latanoprost, we have betaxolol and brimonidine. What exactly is timolol? Timolol is a non-selective beta blocker. It's a non-selective beta blocker, which means it tends to block both beta 1 and beta 2 receptors, even beta 3 also. Latanoprost, on the other hand, is a prostaglandin PGF2 alpha analog agent. Betaxolol is a beta 1 selective blocker. It's a beta 1 selective beta blocker. We had that specific name for that, remember, cardioselective beta blocker. Brimonidine is an alpha 2 agonistic agent. Brimonidine is an alpha 2 agonistic agent. Now let's look at the treatment options for glaucoma. What exactly is glaucoma? Glaucoma is simpler. There is going to be an increased intraocular pressure. Why is there an increased intraocular pressure? Why? Because there is going to be either increased secretion of aqueous humor or decreased drainage of aqueous humor. Either the synthesis of aqueous humor is going to be increased or the drainage is going to be compromised. These are the two major concepts of why there is going to be increased intraocular pressure. How do we treat this particular condition? All these drugs which is given in this list can be used in the treatment for glaucoma. To say the latanoprost, PGF2 alpha analog agents are currently the drug of choice for the treatment for chronic or simple glaucoma. Right? For acute angular closure glaucoma, that is not the drug of choice. For chronic simple glaucoma, this is the latanoprost is the drug of choice. But unfortunately, this is a patient who has glaucoma and bronchial asthma. To understand further, we need to have a knowledge on where exactly is beta 1 receptor situated, where exactly is beta 2 receptor situated. Where is beta 1 receptors, guys? We know beta 1 receptor is there in heart and in the kidneys. Beta 2 receptors, it is there in your bronchial smooth muscles, it is there in uterus, it is there in GI tract smooth muscles, it is there in bladder and many different areas, especially we have blood vessels. Beta 1 receptor is a GS coupled receptor. Beta 2 receptor also is a GS coupled receptor, which means GS receptor, I hope you remember that from general pharmacology itself. What is GS receptor tends to produce what? If it is there on the surface of a smooth muscle, it produces relaxation. If it is there on cardiac muscle, it produces contraction. Beta 1 receptor, if it is there in heart, it is going to be producing contraction, which means it tend to have positive inotropy, positive chronotropy and positive dromotropic effect. Simple. If it is acting at kidney, it is going to be increasing the renin release. It is going to be increasing the renin release. What about beta 2 receptor? This is what the deciding factor as per this question is concerned, guys. Beta 2 receptors is a GS coupled receptor. All these things which we have listed here is going to be producing relaxation. In all these areas, there is going to be relaxation. The point which we are going to talk about in this particular question is bronchial smooth muscle relaxation produced by beta 2 receptor because it's a GS coupled receptor. Now, let's come back to the question again. In this, we have one drug which tends to block beta 2 receptors. This drug tends to block beta 2 receptors, and that's why this drug tends to worsen bronchial asthma. And what was that option again? Here the answer is actually timolol. Timolol is a non-selective beta blocker because it's going to be blocking beta 1 and beta 2 receptors. If it is blocking beta 1, it's going to be decreasing the heart rate. But if it is blocking beta 2, it might worsen. It might induce bronchoconstriction, thereby worsen bronchial asthma. That's the concept of this question. The answer for this question is going to be timolol. I have a doubt. The doubt is, sir, I'm going to administer timolol only as drops, right? Only as eye drops. Then how come it is going to be producing bronchial smooth muscle contraction? How come it's going to be acting at the heart levels? How come it's going to be producing bradycardia? See, timolol, when it is given, we have a reference for that. When you take double the dose of timolol via eye drops, there might be central absorption either via the conjunctival veins, or it might be flowing towards your nose via the nasolacrimal duct. And from there, the drug might get absorbed into the systemic circulation, causing cardiac and other central beta blockade adverse drug reactions, which is not seen with betaxolol. Why? Because betaxolol is a beta-1 selective beta blocker. Only cardiac adverse effects will be there. The bronchial smooth muscle adverse effects will not be there for betaxolol. Latanoprost PGF2 alpha analog, it will not produce any bronchoconstriction, and the same applies for brimonidine, which is actually a derivative of clonidine. This drug also will not produce bronchoconstriction. Let's move to the next question. A 28-year-old female with first trimester pregnancy comes to you in hospital with high levels of T3 and T4. Please note down, the patient is having high levels of T3 and T4. Of course, we know what would be the levels of TSH is going to be decreased most probably. If the patient is having high levels of T3 and T4, this is a case of hyperthyroidism. This is a case of hyperthyroidism. Which of the following drug is most appropriate to use? What are the different drugs which we have in treatment for hyperthyroidism? As per hyperthyroidism is concerned, we have the first and the most important drugs tend to be called as thioamides. These are called as thioamides. Second, we have potassium iodide or any iodide related molecules. And the third one, we have propranolol. And fourth one, we have radioactive iodine. And the fifth one, we have anions. These are the different drugs which we currently have in treatment for hyperthyroidism. But here, within this thioamides, we have two major drugs, guys. We have propylthiouracil and methimazole. Within thioamides, we have propylthiouracil and methimazole. Please note that methimazole is different, clotrimazole is different, albendazole is different. All these drugs names will be ending with zole, but these are different. Methimazole is a drug which can be used for hyperthyroidism. Now here comes the question. The question is regarding which of the following drugs is most appropriate to use in a pregnant woman on her first trimester of pregnancy. We have to know which drug is contraindicated in pregnancy and which drug can be safely administered in terms of pregnancy. But before that, which drug do you think is going to be the most potent one? Most potent one out of all these two, propylthiouracil and methimazole, the most potent one is methimazole. Methimazole is the most potent agent, which means, practically speaking, we have to treat the patient with methimazole, but unfortunately, we don't use methimazole because methimazole is highly teratogenic in nature. The patients or the babies might be landing up in aplasia cutis. This is the type of teratogenicity which can be expected with methimazole, and also the derivative or the prodrug carbimazole, both are one and the same. Aplasia cutis means loss of skin development in the scalp. That's called as aplasia cutis. Apart from that, the patient also might develop fetal goiter. Not the patient, the fetus might develop goiter. These are the two major teratogenic adverse drug reactions which can be expected with methimazole or carbimazole, aplasia cutis and fetal goiter. Even though propylthiouracil is the least potent agent, even though it is less potent as compared to methimazole, this drug can be safely administered in terms of pregnancy. Point number one. Point number two, propylthiouracil has got additional mechanism. It tends to inhibit peripheral conversion of T4 to T3. Peripheral conversion of T4 to T3 also will be inhibited by propylthiouracil. Because it is safer to be administered in pregnancy, we prefer giving propylthiouracil for the first trimester of pregnancy, which means in terms of first trimester, I prefer giving propylthiouracil. Once the developmental phase has been finished off, that is in the second trimester and in the third trimester, I shift the patient from propylthiouracil towards methimazole. Second or third trimester, we shift the patient towards methimazole or carbimazole. Is that clear? Why do we use propylthiouracil? Because this drug is safer to be given in pregnancy. But don't you think any other adverse effects is there for propylthiouracil? What are the adverse effects of propylthiouracil? Most important one, it tends to produce severe, very severe hepatotoxicity. It tends to produce severe hepatotoxicity, which is even more than methimazole or carbimazole. That's the reason why in this condition, in this patient, a 28-year-old female with first trimester of pregnancy, which drug can be safely administered? Propylthiouracil can be safely administered in this patient. I cannot administer carbimazole because it might produce aplasia cutis or fetal goiter. Potassium iodide also is not preferred. Propranolol also is not preferred because propranolol again is a non-selective beta blocker. Propranolol, how do we use it in terms of hyperthyroidism, guys? Why? Because propranolol is a beta blocker. Yes, it might reduce the anxiety related symptoms associated with hyperthyroidism. But on the other hand, it also inhibits the peripheral conversion of T4 to T3, a similar mechanism like what we have propylthiouracil. That's also one of the reasons why we use propranolol in treatment for hyperthyroidism. Here the answer is going to be which drug could be the most safer drug? Propylthiouracil. We'll move to the next question. A 29-year-old female with history of hypercoagulative disorder visiting OPD for anticoagulation treatment. Which of the following drugs should be avoided in first trimester of pregnancy? This is again a contraindication regarding pregnancy. So this patient has to be under treatment with an anticoagulation therapy. But if the patient is planning to get pregnant, what drug should be avoided? We have enoxaparin, unfractionated heparin, warfarin, low molecular weight heparin. See, in this concept, we have to know that the safest drug to be given in terms of pregnancy is concerned. Anticoagulant drug which is safest to be given in terms of pregnancy is heparin. Which heparin? Is it unfractionated or low molecular weight heparin? Just find it out. Safer in pregnancy. The safest drug to be given in terms of pregnancy is heparin, guys. Which heparin? Is it unfractionated or low molecular weight? Both can be safely administered. Both unfractionated heparin and low molecular weight heparin can be safely administered in pregnancy. But we prefer giving low molecular weight heparin. Why do we prefer giving low molecular weight heparin? Because it has got stable pharmacokinetic features. That's the reason why we use low molecular weight heparin. We prefer giving LMWH more than unfractionated heparin. So here, what are the options? The question is what? Which drug should be avoided in first trimester of pregnancy? What is enoxaparin? This is a type of low molecular weight heparin. This drug can be administered in pregnancy. Unfractionated heparin can be administered in pregnancy. Low molecular weight heparin, option D, also can be safely administered in terms of pregnancy, whereas the only drug which is not there out of all the heparin areas is your warfarin, which is the answer for this question, buddy. Why warfarin is not administered? What exactly is the mechanism of action of warfarin, buddy? Warfarin is a drug which tends to inhibit vitamin K epoxide reductase enzyme. Warfarin is a drug which tends to inhibit vitamin K epoxide reductase enzyme. This drug can be given via per oral route. It has got very high plasma protein binding property. It has got a very high plasma protein binding property. It is also a weak acidic agent. Warfarin also is a weak acid drug. So why do we give this drug? Why warfarin is contraindicated whereas heparin is going to be indicated in terms of pregnancy is, I'm going to tell you a simple term, and that is heparin is an ionized drug whereas warfarin is an unionized drug. What's the take home point for that? In general pharma we have already explained, buddies. Ionized drugs are non-penetrable and water soluble. On the other hand, unionized drugs are penetrable and lipid soluble. Heparin is an ionized drug. Heparin is an ionized agent, which means this drug is going to be non-penetrable in nature. That's the reason why we don't give heparin via per oral route, guys. We give heparin only via parenteral route. Even when you give it via parenteral route, the drug gains entry into the blood vessels. Inside the blood vessels, it remains there. It is not going to be crossing any barriers. It will not produce any other responses. That's the reason why heparin also will not cross the blood placental barrier also. That's the reason why heparin is safer to be given in pregnancy. On the other hand, warfarin is an unionized drug. Unionized drugs are penetrable in nature. Warfarin is an unionized drug which is penetrable in nature. These are again lipid soluble in nature. That's the reason why this drug can be given via per oral route, because it can penetrate the barriers, gains entry into the blood from the intestines. And as it is remaining as a penetrable drug, from the blood it can move inside the placenta also, leading on to teratogenic reactions. What are the teratogenic reactions seen with warfarin body? Here is what we are explaining here. Nasal hypoplasia, warfarin teratogenicity. Nasal hypoplasia, brachydactyly, stippled epiphysis. These are the three major components as per warfarin-induced teratogenicity is concerned. So, we have seen about two major teratogenicity till now. Methimazole or carbimazole-induced teratogenicity, what's the type of it? Warfarin-induced teratogenicity, what's the type of it? So, the answer for that question is going to be warfarin, that is exactly avoided in this patient. The next question, a patient is suffering from breast carcinoma, is on chemotherapy, taking multiple anti-cancer drugs. Yeah, we give anti-cancer drugs as a combination in treatment of CA breast. As cancer is not responding to low dose therapy, there is a need to increase the dose of chemotherapeutic agents. There is a need to increase the dose of chemotherapy agents. Which of the following drug requires monitoring of bladder function with the increasing dose? Simply put, which of the following drugs produces bladder related adverse drug reaction? This is just a small clue, guys. This clue is when you see a long question, no? Right? When you see a long question, don't worry, you will not be facing extremely long questions, maximum 3 or 4, maximum 5 lines you will be getting that. When you see this kind of a long question, we have a small key to crack it easily. Go through that question and close your eyes. Try to convert that question into a one-liner. Try to convert it into a one-liner. Once you convert it, it will be easier. Your thoughts will be clear. So what I'm going to do is, I have given this long question, I've read all this, and I'm going to close my eyes and convert it into a one-liner. And that one-liner is, which of the following drugs produces bladder-related adverse drug reaction? That's the question. Now, with that concept in mind, look at the options. Gemcitabine, cisplatin, methotrexate, ifosfamide. Some of you would have easily guessed the answer, guys. But anyhow, let's start with the first one. Gemcitabine is a drug which produces maximum or more diarrhea. Gemcitabine is famous for its production of diarrhea, point number 1. Cisplatin. Cisplatin are platinum compounds. These platinum compounds are associated with emesis. Highly emetogenic anti-cancer drugs are platinum compounds. Out of all the platinum compounds, platinum we know, platin, drug name is ending with platin means it's a platinum compound. These are most emetogenic drugs which we currently have. Point number 2, it might also be associated with the nephrotoxicity. It might also be associated with nephrotoxicity. Methotrexate, what about methotrexate? The most common adverse effect is methotrexate produces mucositis. Remember methotrexate, right? Just you will think like you are spitting it out, right? Methotrexate means there is going to be mucositis. Remember that. Most common one. Next, some patients might develop renal damage. Some patients might develop renal toxicity or renal damage. Again, one of the other most important adverse effect is bone marrow depression. So, bone marrow depression is seen with any anti-cancer drug. And why are you writing especially for methotrexate? Why? Because bone marrow depression is more profound with any nucleic acid acting drugs, especially DNA synthesis inhibitors like methotrexate. And the last one is patients might also develop overdose of methotrexate. Because methotrexate, usually we can use it for many different conditions, guys. We can use it for choriocarcinoma. Apart from cancer-related conditions, it can also be used for rheumatoid arthritis. And also in terms of refractory psoriasis, I can use this methotrexate. In those conditions, methotrexate has to be administered as a weekly dose, right? Weekly 5 milligram or 2.5 or 7.5 milligrams. Weekly, every weekly, one single dose has to be taken. There is more chance the patient might mistake it and take it up daily, methotrexate. If a patient takes up too much tablets of methotrexate, how do we correct it? Like, you know, digibind, right? What is digibind? Drug which is used against digoxin and digitoxin. Similarly, we have a drug called as glucarpidase. Glucarpidase Glucarpidase is a methotrexate cleaving enzyme. It's an enzyme which is used in therapy. This glucarpidase, when it is taken, it goes and binds with methotrexate, inactivates methotrexate. That's the mechanism of it. What about the last one? Here, till now, we have not seen about bladder, guys, right? See, here we are talking about renal toxicity. We have spoken about renal toxicity, not bladder toxicity. Of course, the answer for this question is going to be ifosfamide, because not only ifosfamide, also cyclophosphamide. Both ifosfamide more than cyclophosphamide, both are associated with hemorrhagic cystitis. Hemorrhagic cystitis. There might be bladder inflammation leading on to bleeding. That might be also seen with ifosfamide or cyclophosphamide. How can we treat it? How can we treat it? We have two different options, guys. How can we prevent it? How can we treat it? Two major options. Please remember this. How can we prevent it and how can we treat it? This can be prevented when the patient is on ifosfamide. When you give a high dose of ifosfamide for the patient, you can prevent the development of hemorrhagic cystitis by giving severe or extreme hydration. Extreme hydration might prevent the development of hemorrhagic cystitis, or if a patient develops hemorrhagic cystitis, treatment is going to be, yes, exactly, MESNA, mercaptoethane sulfonic acid. Right? MESNA is the treatment of choice for hemorrhagic cystitis due to ifosfamide. So the question is going to be what? Which of the following drugs requires monitoring of bladder function with increasing dose? That is, which drug tend to produce bladder toxicity? And the answer for this question is going to be ifosfamide. Moving on to the next question. A patient of MI, myocardial infarction, taking antiplatelet drug aspirin tablet 325 milligram. Which other drug be added to above treatment to enhance the antiplatelet activity? We have to look at the options: warfarin, heparin, clopidogrel, and dipyridamole. First of all, how aspirin is going to be useful in treatment of, how aspirin is going to be useful as an antiplatelet. We need to know that, right? See guys, consider here is where your platelet is. We have a platelet here. You remember, platelet doesn't have a nucleus. Remember that? Yeah, these are anuclear molecules. On the platelet, we have this membrane, right? We're just going to draw this membrane. From the membrane, what exactly is going to be happening? From the platelet cell membrane, there's going to be synthesis. To say, consider we have the phospholipid bilayer. We have the phospholipid bilayer. That's what the cellular membrane is. From phospholipid bilayer, there is going to be synthesis of arachidonic acid with the help of phospholipase A2. Phospholipase, why is it called as A2, guys? Because the product which is synthesized is arachidonic acid, A2. PLA2 is responsible for breakdown of phospholipid bilayer towards arachidonic acid. Arachidonic acid in turn will be acted upon by cyclooxygenase enzyme, leading on to the production of prostaglandin G2, H2, and from prostaglandin G2 or H2, there is going to be synthesis of thromboxane A2 with the help of an enzyme called as thromboxane A2 synthetase enzyme. Thromboxane A2 synthetase enzyme. What is the function of thromboxane A2? This is responsible for production of vasoconstriction and platelet aggregation. Platelet aggregation. Two major functions are there for thromboxane, guys: vasoconstriction, platelet aggregation. Now here we have given, this is what happens. For example, whenever the blood vessel is there, if it is getting broken down, the first platelet comes into that. Inside the platelet, if you just zoom in inside the platelet, what is happening over there? From the phospholipid bilayer, arachidonic acid, prostaglandins, that is thromboxane will be synthesized. Thromboxane in turn will be released out from the platelets which are there, which are accumulated in that. These thromboxanes in turn will produce vasoconstriction. Whenever there is bleeding, physiological mechanisms will produce vasoconstriction to prevent the bleeding from occurring. What is that physiological mechanism? It's thromboxane. Here, it also produces platelet aggregation. More platelet tend to be aggregated there. How do we prevent this platelet aggregation from happening, buddy? We give aspirin. What's the function of aspirin, doctors? Aspirin tend to be inhibiting cyclooxygenase enzyme. By what mechanism? Non-competitive, irreversible inhibition of cyclooxygenase enzyme. If that is getting inhibited, what will happen, guys? Thromboxane A2 will not be synthesized, and that's the mechanism of how aspirin can be used as an antiplatelet drug. Now we'll move back to that question. Which of the following drug can be added to enhance the antiplatelet therapy? Warfarin. What is actually warfarin? It is not an antiplatelet drug. It is an anticoagulant drug. What's the mechanism? Inhibits vitamin K epoxide reductase, thereby decreases the synthesis of vitamin K dependent clotting factors. What are the vitamin K dependent clotting factors? 2, 7, 9 and 10. These are the vitamin K dependent clotting factors. Heparin, again, it's an anticoagulant drug. Clopidogrel, this is an antiplatelet drug. Dipyridamole also is an antiplatelet drug. What's the mechanism of clopidogrel? Clopidogrel is a drug which tend to bind and inhibit ADP receptors. ADP receptor blocker. Dipyridamole, on the other hand, has got two different mechanisms. The first one is it serves as adenosine reuptake inhibitor. It inhibits adenosine reuptake. It also inhibits phosphodiesterase 3. It can be used as an antiplatelet drug, but currently we don't use it. Why? Because there is more chances of some property. Remember that? It's called as coronary steal phenomena. Dipyridamole is associated with coronary steal phenomena. That's why we don't use dipyridamole as an antiplatelet drug or even for MI patients. So this patient is a known case of MI, so we don't want to risk it. So what do? We give clopidogrel in this patient as an additive concept, which can be used as to increase the antiplatelet activity of aspirin. We'll move to the next question. LD50 stands for, everyone knows the full form, right? It's lethal dose in 50% of the population. That's what LD50 is. Just exactly, let's look at what exactly is this LD50. Consider you have a patient, and the patient has been complaining of vomiting. You open your drawer and you find two drugs over there, drug A and drug B. Which drug? Both of these drugs will stop the vomiting for the patient. But how do we choose which drug to be given for the patient? We have two antiemetics. Both drugs tend to produce stoppage of vomiting, but how do we choose that? We use this value. We take up 100 animals, we induce vomiting in 100 animals, and we give drug molecule A, and we see how many animals vomiting is getting stopped off. Out of 100, consider drug molecule A, 30 animals vomiting has been stopped. Drug molecule B, when you administer, out of 100, 60 animals vomiting has been stopped, which means drug molecule B is a better drug compared to drug molecule A, and you administer B to the patient. How do we calculate that? We calculate a particular value called as therapeutic index. We have a particular value called as therapeutic index. Therapeutic index is nothing but the ratio between TD50 by ED50. What is TD50? Toxic dose in 50% of the population, effective dose in 50% of the population. 50% of the population means out of 100 animals, 50%. If there is 200 animals, out of 100 animals, that's called as 50%. If there is 1000 animals, 500 animals will be the 50% of the population. We know that, no? This simple mathematics. TD50, let's talk about ED50 first. ED50 means effective dose in 50% of the population. For example, we had the drug molecule A, right? It stopped the vomiting of how many? 30 animals, or out of 100, 30 animals vomiting has been stopped. 30% of the animals vomiting has been stopped. You increase the dose of drug molecule A, 40%. You increase the dose of drug molecule A, 50%. That dose is called as effective dose in 50% of the population. Now what I do is I take up very higher doses of that drug, right? Consider this is around 10 milligrams. Consider I take 100 milligram. I administer 100 milligram to all those 100 animals. Out of 100, when you give 100 milligram out of the to the 100 animals, consider around 30 animals toxicity symptoms have been developed. You give 120 milligrams, 40% of the animals develop toxicity symptoms. You give 140 milligram, 50% of the animals develop toxicity symptoms. That 140 milligram will be called as toxic dose in 50% of the population. It's called as TD50. Previously, we had a nomenclature called as LD50. LD50 means lethal dose, but currently we don't use it because we don't want to kill any of the animals. So we have to look at only the toxicity symptoms which the animals or the human beings is going to be developing. So LD50 is going to be called as lethal dose in 50% of the population. This ratio is going to be established as a safety phenomena. Therapeutic index is going to be directly proportional to the safety of a drug, which means consider we have two drugs. The first drug's therapeutic index is 2. The second drug's therapeutic index is 10. We say that therapeutic index 10 is the safest drug as compared to therapeutic index 2. Why? Because as I've told, therapeutic index is directly proportional to safety. Let's move back to this question. LD15 stands for what? 50% of animal mortality in an experimental exposure of drug. It appears like the right answer, right? 50% effect of drug in animal sample, that is called as what? No, we have no different things like 50% effect is produced. No, it's not there. See, the words are confused. Words are actually they are jumbled, right? 50% effect means when the patient has got vomiting, 50% vomiting has been stopped. Is that possible? We can't even calculate it, right? No. Death of 50 animals in an experiment. Out of 100, 50 is called as 50%. As I've told, death of 50 is not a common number. 50% is the common number. 50% reduction of infection in given population of animals, that we can call it as ED50 of an antibiotic drug. That's also not the option. So the answer is going to be 50% of animal mortality in an experimental exposure of drug. Which of the following statements is incorrect? Carbamates bind to acetylcholinesterase irreversibly. Atropine is used as an antidote for organophosphorus compounds poisoning. Pralidoxim has its role in reversal of enzyme in carbamates poisoning. Atropine is used as an antidote for carbamate. For understanding this, you have to have a knowledge on 3 major points. Point number 1, how organophosphorus produces its symptoms, how the patient develops symptoms because of OPC poisoning. Point number 2, how atropine is used in this condition, how pralidoxim is going to be used in this condition. Clear? Let's talk about organophosphorus compounds. Consider, we know that what's the mechanism of action of OPC? These drugs are competitive, irreversible acetylcholine esterase inhibitors. I am going to draw the structure of acetylcholine esterase enzyme. It contains 2 active sites, anionic site and esteratic site. This is the structure of acetylcholine esterase enzyme. Now, what will happen when you give an organophosphorus compounds to when the patient takes up organophosphorus compounds? So what will happen to the acetylcholine esterase enzyme? This organophosphorus compound will bind only with one site, and that is esteratic site. This OPC will bind with the esteratic site. It will not bind with the anionic site. That's what organophosphorus compounds is. But this is not true for carbamates poisoning. Carbamates are a different set of drugs which will bind with both anionic and esteratic site. Carbamates will bind with both anionic and esteratic site. of acetylcholinesterase enzyme. If organophosphorus compounds is binding with the esteratic site of acetylcholinesterase will be inhibited. When that is getting inhibited, more acetylcholine tend to be accumulated in the body. More acetylcholine will interact with muscarinic receptors. More acetylcholine will interact with nicotinic receptors, producing cholinergic symptoms. That's the mechanism of how OPC or carbamates is going to be producing responses in the human body. How do we treat this condition? How do we treat OPC poisoning? We have two major drugs to be given, guys. The first one is atropine. What's the mechanism of action of atropine, guys? Atropine is it's not an anticholinergic drug. Yeah, it's actually anticholinergic, but we have a separate term for it. It's called as an anti-muscarinic agent. I hope you can understand where I'm coming. If you say anticholinergic agent, it means this drug is going to be binding and inhibiting or blocking both muscarinic and nicotinic receptors. It's not so. Atropine will bind and inhibit only muscarinic receptor. So it's purely an anti-muscarinic agent. It's an anti-muscarinic agent. As it is blocking the receptors, muscarinic receptors, it prevents the development of muscarinic symptoms. So muscarinic symptoms will not occur. Muscarinic symptoms will not occur, but the patients might be having nicotinic symptoms. Nicotinic symptoms might be there. Muscarinic symptoms will be blocked by atropine, but the patients will be having nicotinic symptoms. If the patient develops nicotinic symptoms, patients will be persistently having it. This is the major issue with atropine. What about the second drug? We have oxims. Oxims. What's the function of oxim, guys? Oxim is one of the most laziest drug, guys. Why is it called as laziest drug? Why? Because this drug is going to be, it cannot stand and perform its function. It needs to sit down and produce its function. Not just any seeds. The oxim needs to sit down at the anionic site. Oxims needs to sit down at the anionic site only after it is, after it is binding at the anionic site. It forms an irreversible bondage with organophosphorus compounds, and both OPC and your oxims will be thrown out. So both OPC and oxims will be thrown out. Thereby, it is going to be reactivating the acetylcholinesterase enzyme. This is what we explain it as acetylcholinesterase reactivator. Reactivators. Consider you are sitting down and you are sitting down in your theater with your popcorn. Clear? Now one more guy comes. He comes over there. He comes to the nearby seat. He takes the popcorn and he goes away. And that guy is what we explain it as oxims. And you are what we explain it as your acetylcholinesterase enzyme. So acetylcholinesterase enzyme is there. It is bounded with the organophosphorus compounds. Now hereby we have the anionic site. The guy that is the nearby guy, that is your oxims, will come and bind with the anionic site. It will bind with the organophosphorus compounds, and both is going to be thrown out, thereby reactivating the acetylcholinesterase enzymes. Why am I repeating that again and again? Why? Because from this you can clearly understand for the function of oxims, we need which site? Anionic site. Which means, can I use oxims for carbamates poisoning, buddy? No. I cannot use oxims for carbamates poisoning. Why? Anionic site is not free. So the mechanism is these drugs are acetylcholinesterase reactivators. Reactivators. It can clear out muscarinic symptoms. It can clear out nicotinic symptoms, because this is not a drug which is blocking those receptors. It is reactivating the acetylcholinesterase enzymes. Thereby acetylcholine gets broken down. Very simple. So it can be easily administered. But we have one negative point regarding atropine and also this oxims, and that is, as we have told previously, this can be given for organophosphorus compounds. This can be given for carbamates poisoning. This can be given for organophosphorus compounds, but cannot be given for carbamates poisoning. Why? Because anionic site is not free. As I've told, oxims are the laziest drugs. It needs to sit down on the anionic site to perform its function. We'll move back to that question. Which of the following statements is incorrect? Carbamates bind to acetylcholinesterase irreversibly. This is a true statement. or to say correct statement. The question is false, right? Atropine is used as an antidote for OPC poisoning. Yes, it's a true statement. Pralidoxim, that is one of the types of the oxims, has its role in reversal of enzyme in carbamates. Very clear here. This is the wrong statement because it cannot be used for carbamates poisoning. Oxims can be used only for organophosphorus compounds poisoning. Atropine is used as an antidote for carbamate. Yes, because for atropine there is no anionic restorative site issues. Clear? Because it's just going to be blocking the muscarinic receptors. Thereby, it prevents the acetylcholinesterase from producing its effects. So, simply put, towards the drug of choice, atropine is the drug of choice. The second drug of choice, if you want to ask, I will be explaining oxims will be the second drug of choice for treatment of OPC poisoning. For carbamates, only one drug is there, and that is atropine. We'll move on to the next question. A 70-year-old Parkinson disease patient suffers from constipation. After taking an anti-Parkinsonian treatment, which of the following drug may be responsible for above symptoms? So, what I'm going to do, I'm going to close my eyes and convert it into an one-liner. What's that one-liner? Which of the following drugs produces constipation? Is that right? That's what the question is. Which of the following drugs is associated with constipation? Levodopa we have benztropine, pramipexole, metoclopramide. Metoclopramide can never come into this option. Why? Because metoclopramide is a drug. It's a prokinetic agent. It tends to induce Parkinson's. It's an example of drug-induced Parkinson's. So, it cannot be used in treatment of Parkinson's. So, metoclopramide is not going to be coming under these options. Pramipexole. What is pramipexole? It's a dopaminergic agonistic agent. It's a dopaminergic agonistic agent. The most important and recurrently asked question, the adverse effect of pramipexole and ropinirole. Pramipexole and ropinirole are impulse controlled disorders. These are impulse control disorder. What is an impulse control disorder? Simple, pathological gambling. That's what impulse control disorder means. Pathological gambling. Hypersexuality. These are characteristically seen with ropinirole and pramipexole. Both of these drugs has been recently approved, not recently, 2 years before. It has been approved for as a monotherapy for restless leg syndrome. So, this drug also is an anti-Parkinsonian drug. So, this drug is not producing constipation, guys. Please have that concept in mind. What about levodopa? Levodopa adverse effect is the most common or the most early adverse effect is vomiting, guys. Please remember, it's very important. Levodopa induced vomiting, very common, very important one. This levodopa induced vomiting, what will be the treatment of choice? You give metoclopramide? No, you don't give metoclopramide. Why? Levodopa is used for Parkinson's. Metoclopramide will worsen Parkinson's, so we never give metoclopramide. Metoclopramide is contraindicated for levodopa-induced emesis. Then what will be the drug of choice for levodopa-induced emesis? Domperidone will be the drug of choice. The treatment is domperidone. Why are we always talking about metoclopramide and domperidone? Why aren't we talking regarding ondansetron, a famous antiemetic, then any other apripita? No, we don't use that in terms of this condition. Why? Because the vomiting because of levodopa is due to its action on dopaminergic receptors in chemoreceptor trigger zone. So, we have to give a drug which blocks the dopaminergic receptors. Only then I can use it specifically for levodopa-induced emesis. Out of all the dopaminergic blockers, we have two drugs, domperidone, metoclopramide. We don't use metoclopramide, we use only domperidone because metoclopramide worsens Parkinson's. Answer for this question is going to be benztropine. We also have other adverse effects of levodopa, guys, like dyskinesia. Patients might develop dysgeusia, cardiac arrhythmia, psychosis. Many different things are there, but I'm just going to be sticking on to this question. The answer is going to be benztropine. What is benztropine? It's an anticholinergic agent. Benztropine is an anticholinergic agent. We know that cholinergic system increases GI motility. So, there is going to be defecation. On the other hand, when you give an anticholinergic agent, GI motility is going to be blocked. When it is getting blocked, patients might develop constipation. Constipation, dry mouth, dry eyes, these are classical adverse effects of anticholinergic drugs. Especially when it is given in terms of elderly, it is more pronounced. Constipation is very much pronounced. We'll move on to the next question, guys. A person presented to emergency in comatose state after consuming some unknown poison. Excessive sweating, point number 1. Sweating, profuse sweating tend to occur, is apparent. And on examination, there is bradycardia, point number 2. Heart rate has decreased. BP is 80-60 millimeter mercury. BP has fallen down. Which of the following is an antidote for treatment of this patient? Which of the following is an antidote for treatment of this patient? So I am just going to try to close my eyes and find out the answer for it, right? What exactly is this condition, guys? I will simply say the answer. It's organophosphorus compounds poisoning. Why is it? Because we have lots of mnemonics, remember that, guys, like dumbbells, smudge, many different mnemonics are there. But the concept is, if you have read regarding autonomic nervous system, and if you have understood where all the muscarinic receptors are there, where all the nicotinic receptors are there, there is no need for the mnemonic there. Clear? Muscarinic receptors can be of many different types. We have M1, M2, M3, M4 and M5. Out of all these agents, M1, M2 and M3 are the most important ones. M2 is going to be there in heart, whereas M3, what are its locations? M3 is there in the exocrine glands, it is there in the GI tract, it is there in the pupillary sphincter, it is there in ciliary muscles, bronchial smooth muscles, bladder smooth muscles. M4 and M5 are lesser type of receptors. It is there. We have seen it in central nervous system, but major function is very much limited. M1 is there in your enterochromaffin-like cells. M1 is there in your enterochromaffin-like cells. M2 is a GI. We all know that muscarinic receptors are all G protein coupled receptors. You remember with this mnemonic QI, QI, Q. GQ, GI, GQ, GI and GQ, which means M1 is a GQ coupled, M2 is GI, M3 is GQ, M4 is GI, M5 is GQ. As M2 receptor is a GI coupled receptor, it is associated with decreased heart rate, and that is what is seen in this patient. M3 receptor is going to be is a GQ coupled receptor. So what is going to happen? There is going to be increased exocrine gland secretion. There is going to be increased GI motility. There is going to be increased constriction of pupillary sphincter, causing meiosis. There is going to be ciliary muscles contraction, causing accommodation. We know that ciliary muscles is involved in accommodation. Bronchial smooth muscles are constricted, causing bronchoconstriction. Bladder smooth muscles are constricted, causing urinary voiding. So here in this patient, we can see that the patient is having excessive sweating. Point number 1. Excessive sweating is nothing but increased exocrine gland secretion, which is seen with increased acetylcholine. Bradycardia, because it is going to be producing decreasing heart rate. More acetylcholine will bind with the M2, decreases the heart rate. BP is 80-60. Why is the BP decreased? Acetylcholine itself can produce vasodilatation, producing decreased blood pressure. This is clearly a case of cholinergic crisis. More acetylcholine is going to be there within the body. Now what I am going to do, I am going to close my eyes and find out what are the different poisoning which might increase the cholinergic system levels in the body, and the answer is going to be organophosphorus compounds. Which of the following is the antidote for the treatment of this patient? So what I am going to do, convert it into an one-liner. What is the drug of choice, or what is the antidote for organophosphorus compounds poisoning? We have seen that previously very clearly. Answer is what? Atropine is the answer for the question. So it's going to be atropine. Atropine is the answer for OPC poisonings. Drug used for the treatment of pregnancy-induced hypertension is. You will be having lots of doubt regarding whether it is alpha-methyl-dopa or any other drugs. The answer as per the options which is given here is alpha-methyl-dopa, lisinopril, hydralazine, telmisartan. The answer is going to be, compared to the other options which is given here, alpha-methyl-dopa is going to be the answer for it. What are the other drugs which can be used for pregnancy-induced hypertension? We have a mnemonic for that part is pregnant hypertensive lady chooses dolo. This is the mnemonic. Remember the drugs which can be used in pregnancy, antihypertensive drugs in pregnancy. With the mnemonic pregnant hypertensive lady, you can understand that this mnemonic is for treatment of pregnant hypertensive women. Pregnant is for prazosin. Pregnant is for prazosin. Hypertension is for remembering that this mnemonic is for hypertension. Lady, LA is for lazins. Lazins means hydralazine. Hydralazine. DY is for dihydropyridines. DY is for dihydropyridines. Dihydropyridines means what? Calcium channel blockers. And what are those? Dihydropyridines. Dipins are the drugs. Amlodipine, nifedipine, nicardipine. These drugs can be safely administered in terms of pregnancy. Chooses is for clonidine. Chooses is for clonidine. DO is for dopa, alpha methyl dopa, and that's what the option which was given in this question. Low is for labetalol. Labetalol is what drug, guys? Labetalol is actually an alpha plus beta blocker. Alpha 1 plus beta 1 blocker. Both labetalol and carvedilol tend to have blockade of both alpha 1 and beta 1 receptors. One more important point regarding labetalol is labetalol tend to have cocaine-like adverse drug reactions or cocaine-like effects. It inhibits norepinephrine reuptake also. That is seen with labetalol. But here comes the question. Which will be the drug of choice in terms of pregnancy-induced hypertension? I will opt for labetalol. Labetalol is the drug of choice for pregnancy-induced hypertension. But unfortunately, we don't have labetalol in that options. We only have alpha-methyl-dopa in that option. So the answer is going to be alpha-methyl-dopa. Lisinopril, absolutely contraindicated. Telmisartan, absolutely contraindicated. Why? Not only this lisinopril and telmisartan, guys, all the drugs which are blocking the RAS system. Drugs which are blocking the RAS system, no? What are those? We have AC inhibitors, angiotensin receptor blockers, and renin inhibitors. What are the AC inhibitors? Drugs name which are ending with pril, lisinopril, perindopril, enalapril. ARBs, Artan drugs or Satan drugs, angiotensin receptor antagonistic agent. Renin inhibitors are your Kiran drugs, Aliskiran, Inalkiran, Remikiran. All these drugs are contraindicated in pregnancy. Why? Because it might produce renal damage in fetus. Common adverse effect of all these three is these drugs might produce renal damage even in adults also. When it is given in pregnancy, it may cross the blood placental barrier, causing renal damage in the fetus. That's the reason why lisinopril, it's an AC inhibitor. Telmisartan is an angiotensin receptor blocker. Both these drugs are absolutely contraindicated. Hydralazine can be administered in pregnancy, but this is not the drug of choice. If you ask about alpha-methyl-dopa or hydralazine, I will choose alpha-methyl-dopa. If you ask alpha-methyl-dopa or labetalol, I will choose labetalol. A 56-year-old patient who is a known case of hypertension was being treated with antihypertensive drugs. He is having chronic cough since 2 weeks. He was started on antimicrobials, but cough did not resolve. I don't know why the patient was started on antimicrobials for cough. Which of the following antihypertensive drug may induce chronic cough in this patient? This is again a question of antihypertensive drugs. Simply put, close your eyes. Which of the following drugs produces chronic cough? That's the one-liner question for that. Am I clear? ACE inhibitors, of course, majority of you would have found it out. ACE inhibitors, the classical adverse drug reaction is it produces dry cough. This cough is not seen with ARB. It is not seen with renin inhibitors. Classically seen only with ACE inhibitors alone. Why? Because ACE inhibitors not only decreases the levels of angiotensin, it decreases the levels of angiotensin, but that is not the primary cause of chronic cough. The cause of chronic cough is it tend to increase the levels of bradykinin. Bradykinin will be accumulated in the body. Because of that, the patients will develop chronic cough. So what we are searching for? We are searching for ACE inhibitor in the options, right? Again, convert the question to one-liner. Which of the following is an ACE inhibitor? We have converted a grade or level C question towards a level A question, right? What's the drug? Pril drug. Yes, direct question. The answer is lisinopril. Minoxidil will not produce cough. Propranolol will not produce cough. Amlodipine is actually a calcium channel blocker. Minoxidil is a potassium channel opener drug, guys. It can be used for hair loss, male pattern baldness. Propranolol is a beta blocker, that is non-selective beta blocker. Non-selective beta blocker. This drug is contraindicated in bronchial asthma. Because it's a non-selective beta blocker, it might worsen the bronchial asthma condition. Amlodipine is a calcium channel blocker. One of the long-acting calcium channel blocker is amlodipine. Only calcium channel blocker which can be safely administered in terms of angina. In angina, dipine drugs should not be administered, especially short-acting drugs should not be administered. Long-acting drugs can be safely administered. Amlodipine is one of the drugs which can be safely administered in terms of angina, prophylaxis of angina. Answer for this question is going to be lisinopril. A professor in medical college is teaching students about adverse effects of a drug. Which of the following drug can cause gynecomastia in men and menstrual irregularities in women? One-liner. Which drug causes gynecomastia? Am I right? Drug-induced gynecomastia. We have spironolactone, propranolol, misoprostol, oxytocin, a famous mnemonic, and what is that? Disco. Remember that? Disco. Remember mnemonic. Remember the drug which might induce gynecomastia. Digoxin, the drug which is used for congestive cardiac failure, which was used for congestive cardiac failure. Isoniazid, the anti-tubercular drug. Spironolactone, the potassium sparing diuretic. Simply we can also say that aldosterone receptor antagonistic agent. Cimetidine H2 receptor blockers, H2RA. Estrogen, we know it is going to be producing gynecomastia and menstrual irregularities in women. So the answer for this question is going to be what? Spironolactone, because this is the S in the disco. A 50-year-old patient of type 2 diabetes mellitus was controlled on oral hypoglycemic agents. This patient presented to the hospital with profuse sweating and dizziness. Profuse sweating and dizziness. There was presence of hypoglycemia. They have given the diagnosis also, right? Anti-diabetic drug-induced hypoglycemia. Which among the following drugs can result in hypoglycemia in this patient? One-liner. They have given the one-liner in the last. Which of the following drug produces hypoglycemia, right? Which is the hypoglycemic agent? We have metformin, voglibose, vildagliptin, glipizide. Among all the drugs which might produce hypoglycemia, see, even though this group of drugs is called as oral hypoglycemic agents, which is actually a misnomer, guys, is one of the most bullshit name which we can give, because oral hypoglycemic agents means all the drugs are not given via oral route. Not all the drugs produces hypoglycemia, right? So this is actually a misnomer. We can call it as non-insulin anti-diabetic drugs. We can call it as non-insulin anti-diabetic drugs. This non-insulin anti-diabetic drugs, the most important drug which produces hypoglycemia are sulfonylureas. Sulfonylureas, because it serves as an insulin secretagogue agent. It serves as an insulin secretagogue agent. What exactly is this insulin secretagogue? It is going to be, what's the mechanism of action of sulfonylurea? Sulfonylurea tend to block ATP sensitive potassium channels. sulfonylurea tend to block ATP sensitive potassium channels. When these channels are blocked, the beta cells, it is going to be there on the surface of beta cells of pancreas. When the ATP sensitive potassium channels are blocked, potassium efflux will not occur. Potassium will be accumulating inside the beta cells. If positive charge is getting accumulated inside the beta cells will land up in depolarization. This depolarization will further produce calcium influx. This calcium influx in turn will produce exocytosis of the contents. What is the content inside beta cells of pancreas? Insulin is the content. So insulin is going to be secreted more, and that drug has got more propensity to produce hypoglycemia. Which are the, to say, we can simply, we can also change the question like, which of the following is a sulfonylurea? That is the final one-liner. We have converted all the questions towards a level 1 question. Which of the following is a sulfonylurea? Metformin? No, it is a biguanide drug. It will not produce hypoglycemia. It will produce normoglycemia. What is voglibose? It's an alpha glucosidase inhibitor. It's an alpha glucosidase inhibitor. It will also not cause hypoglycemia, guys. Right? Vildagliptin, it's a gliptin agent. Please remember that if the drug name contains GLI in its name, it means it's a drug which is going to be decreasing the blood sugar levels. We can remember glucose inhibition, GLI, remember that. This drug contains GLI, which means it's going to be an anti-diabetic drug. It's PT and IN is there, no? After GLI, we have PT and IN. PT means it's a peptidase inhibitor. Dipeptidyl peptidase inhibitor, that's what vildagliptin is. It will also not cause hypoglycemia, it will produce normoglycemia. What is glipizide? This is what we call it as a sulfonylurea. Out of all the sulfonylurea, the drug which has got lesser chances of hypoglycemia is actually glipizide. But compared to all these drugs, we can opt for glipizide. Glipizide is a drug. Glipizide is going to be the answer for this question. Is that clear? A young boy was brought to the hospital with complaints of few episodes of fast blinking and staring at something for around 20 seconds. No, he is not watching any Insta Reels. Don't worry, because many people who are watching Insta Reels, no, they'll be having the same thing. Fast blinking and staring at the Insta Reels for more than 20 seconds. ECG shows spike and wave pattern. Spike and wave, classical terms. If you come across this spike and wave or vacant stare, these are the classical terms which we come across. Vacant stare, spike and wave appearance in not ECG, it's actually EEG. It's actually in EEG, there's going to be spike and wave pattern. If it is there, is the classical condition of what buddies? It's a classical condition of absence seizures. So this is a case of absence seizures because also it is an young boy. Is that right? Which of the following drugs should be used for this treatment? So what's the question here? One-liner, drug of choice for absence seizures. We have two different options. Usually the confusion occurs, guys. Whether it's going to be ethosuximide or sodium valproate. No need to worry. Sodium valproate is the drug of choice. Right? So here we have sodium valproate. That will be the answer for this question. Phenytoin, this is a sodium channel blocker. This is not administered in terms of absence seizures. Diazepam can be given for febrile seizures. Diazepam, per rectal diazepam can be given for febrile seizures. Carbamazepine, on the other hand, can be used for trigeminal or glossopharyngeal neuralgia, and also in terms of partial seizures. In both of these conditions, I can use carbamazepine. We cannot use carbamazepine or phenytoin for absence seizures. For absence seizures, we need a drug which might be blocking the calcium channels, and that's why we opt for sodium valproate. Is that clear? So the answer for this question is going to be sodium valproate. What is the mechanism of action of TPA? What is TPA at first? It's called as tissue plasminogen activator. It's called as tissue plasminogen activator. See, the concept of this tissue plasminogen activator is purely regarding the blood coagulation concepts, buddies, right? Consider here is where the blood vessel is, and the blood vessel is getting broken down. We have platelets here and there. This is considered, I'm going to draw only 2 platelets over here. You know what is exactly how a clot is going to be there, what exactly it looks like. We have, I'm not drawing all the platelets, I have drawn only 2 platelets here. From the platelets, there will be certain receptors which are expressed out. These receptors are called as glycoprotein 2b3a receptors, GP2b3a receptors. And we have fibrin strands which are attached to it. We have fibrin strands, right? Initially, it is not fibrin. Initially, it is going to be fibrinogen molecules. These are inactive fibrinogen molecules. Then what is this? These are glycoprotein 2b3a receptors. These are your platelets, guys. So, fibrinogen is going to be there in the inactive form. Once it is there in the inactive form, it must be converted to the active fibrin strand. It must be converted to the active fibrin strand. How fibrinogen is going to be converted to the fibrin strand? Simple. Remember that extrinsic and intrinsic pathway is there, no? Coagulation pathway. This coagulation pathway is involved in the conversion of fibrinogen to fibrin. Simply put, clotting factors are involved in the conversion of fibrinogen to fibrin. So we have 2 different platelets with expressed out. What is expressed out? Glycoprotein 2b3a receptors are expressed out. Fibrin strand is going to be connecting that. Clear? Similarly, we have other platelets, fibrin strand, other platelet, fibrin strand, other platelet, fibrin strand. So we are forming a clot completely. Now what's the next step? How do we break down? So we have to wait till the blood vessel wall multiplies, to say it just proliferates and fuses together. Once the blood vessel wall is fused again, there is no need for that clot, right? So now the clot has to get disintegrated. How the clot is going to get disintegrated? Where all there is fibrin, it is pre-attached with the molecule called as plasminogen molecule. It is pre-attached with the molecule called as plasminogen molecule. These molecules are also called as fibrin-bound plasminogen molecules. Very beautiful name, fibrin-bound plasminogen molecules. So what exactly happens is, fibrin needs to be broken down to inactive strands, right? Only if it is broken down to inactive strands, all the platelets will get disintegrated, mixed up with the blood. Who is going to be converting this? Plasmin is responsible for breakdown of fibrin to inactive strands. But plasmin is not the active form. It is going to be there in the inactive form. That inactive form is called as plasminogen. That's what we have drawn it over here. This is your plasminogen molecule. Now comes the next question. Who is going to be activating plasminogen to plasmin? That is what TPA is, right? PA means what? Plasminogen activator. Simple. PA means plasminogen activator. But it is synthesized from the vascular endothelial cells or endothelial tissue. That's why it is also called as tissue plasminogen activator. Tissue plasminogen activator. These are actually derived from the endothelial cells. From the endothelial cells, right? So, what are the different drugs which we have, guys, as per treatment for bleeding disorders is concerned? 3 major topics are there, no? What are those? Anticoagulants, antiplatelets, fibrinolytics. Anticoagulants are the drugs which will inhibit this coagulation factors. Clotting factors is going to be inhibited by the anticoagulant drugs. Platelets and its receptors will be blocked by antiplatelet drugs. Tissue plasminogen activator will be stimulated by fibrinolytic agents. These are going to be stimulated by fibrinolytic agents. Why are they called as fibrinolytics? Because it is involved in the conversion of plasminogen to plasmin. Plasmin means seizures. This plasmin, simply put, here is where the plasminogen is, no? Here is where we can see the plasminogen is there. Once this plasminogen is getting converted to plasmin with the help of tissue plasminogen activator, which are released from the endothelial tissues, plasminogen will be converted to plasmin, which in turn will break down this fibrin strand and platelets will get dislodged. Is that clear? Now comes the question again. What is the mechanism of action of TP? It's more of physiological question, guys. Fibrinolysis. Yes. Inhibition of factor 5 and factor 7, no, this is not done by TPA. This is done by anticoagulant drugs. Inhibition of factor 3 or 5, no. Activation of antithrombin 3, you know what is this? This is the mechanism of action of heparin. Activation of antithrombin. Antithrombin 3 is an old nomenclature. The current nomenclature is antithrombin alone. Heparin mechanism of action is what? Activation of antithrombin is. The answer for this question is going to be fibrinolysis. A patient is taking platinum based chemotherapy. Platinum we have seen somewhere, no? Platinum compounds are most emetogenic anti-cancer drugs for treatment of ovarian carcinoma. Which of the following drugs should be used to prevent nausea and vomiting in this patient? What's the one-liner? Yeah, drug of choice for platinum or cisplatin-induced emesis. That's what the question is. We have domperidone, promethazine, palonosetron, metoclopramide. Have this basic concept in mind. Anti-cancer or chemotherapy-induced emesis, induced vomiting. The treatment of choices, we give a 5-HT3 antagonistic agent along with neurokinin 1 receptor blocker along with a steroid. Why are we giving all these 3 drugs in combination, guys? This 5-HT3 antagonistic agent can be used for early vomiting due to anti-cancer drugs. NK, this is N actually, sorry for that. NK1 receptor blocker is going to be useful for delayed vomiting. 5-HT3 antagonistic agents, these drugs names are cetron drugs, no? So out of all the cetron drugs, I prefer giving palonosetron. Out of all the NK1 receptor antagonistic agent, I prefer giving netopitant. These pitant drugs are actually NK1 receptor blockers. Out of all the steroids, I prefer giving dexamethasone. This is the combination which we administer to prevent or also to treat anti-cancer drugs or platinum compounds induced emesis. This is not the treatment of choice for any other types of emesis, guys, right? Only for chemotherapy induced emesis, we use these conditions. We use these 3 different drugs. Domperidone is the drug of choice for what type of vomiting? Levodopa-induced vomiting. Yes? Yeah. Promethazine is an antihistaminic agent with additional anticholinergic property. Palonosetron is what the answer for this question is. Metoclopramide can be administered, but it is not going to be effective. And most importantly, metoclopramide might induce Parkinson's. Mechanism of action of doxycycline is. What is doxycycline, guys? Tetracycline. I can hear you screaming it out as tetracycline. Just look a little bit further. What is tetracycline and the related drugs? Here we are going to talk about, this is an antibiotic. We know the doxycycline is an antibiotic. As far as antibiotics is concerned, we are going to classify them into 5 major topics. Drugs, what all the antibiotics which we have, which might be inhibiting cell wall of a bacteria, cell membrane of a bacteria, protein synthesis inside a bacteria, nucleic acid synthesis inside a bacteria, folic acid synthesis inside a bacteria. This, as doxycycline is a drug which is going to be inhibiting the protein synthesis, I am going to talk more regarding the drugs which might be inhibiting the protein synthesis. Let's talk about antibiotics which might be inhibiting protein synthesis in a bacteria. We have certain basic drugs, guys. We have certain basic drugs like aminoglycosides, macrolides, tetracycline, chloramphenicol. These are certain basic drugs. Apart from all this, we have certain additional drugs, or to say other drugs. Other drugs like which can be remembered with a mnemonic protein loss FM. Protein loss FM. I thought of putting it as protein loss MF, but MF in English it doesn't appear like a good word, so I changed it to FM. Protein loss FM. Protein means pleuromutilin. Protein means pleuromutilin. L stands for lincosamides. L stands for lincosamides. O stands for oxazolidinones. Oxazolidinones. S stands for streptogramins. Streptogramin. The next S is for sordarin. And also we have spectinomycin. Spectinomycin. F is for fusidic acid. F is for fusidic acid. M is for mupirocin. M is for mupirocin. So these are the different drugs which might be inhibiting the protein synthesis in a bacteria. But out of this, what is pleuromutilin? Retapamulin, that's the drug name. Pleuromutilin is actually a group of drugs names. Retapamulin, lefamulin, all these are drugs names. Lincosamides, clindamycin. Clindamycin, the drug name will be having lin in its name, then it will be called as a lincomycin. Oxazolidinones, I hope you know some drugs which comes under this classification, buddies. I'll give you a clue, drug name which is ending with zolid. Yeah, tedizolid, iparazolid, all these are zolid agents. Streptogramins is nothing but quinupristin along with dalfopristin. Dalfopristin. It's like twins, guys. Quinupristin, dalfopristin is like twins. Why? Because both, this is what we explain it as synergism, guys. Synergism is dalfopristin when given as monotherapy behaves as bacteriostatic agent. Quinupristin, monotherapy, bacteriostatic agent. Combination behaves as bactericidal agent. Sordarin is actually an antifungal drug. It's an antifungal drug. Spectinomycin is a derivative of aminoglycoside, fusidic acid, mupirocin. All these are drugs which is going to be inhibiting protein synthesis in a bacteria. Now we'll move back. Mechanism of action of doxycycline. DNA gyrase inhibitor, no. Cell wall synthesis inhibitor, no. Protein synthesis inhibitor, yes. DNA dependent RNA polymerase inhibitor, no. What's the classical example of DNA gyrase inhibitor? Fluoroquinolone. We have many other drugs also. I will just telling you the basic drugs alone. Cell wall synthesis inhibitors, beta-lactam antibiotics are cell wall synthesis inhibitors. Protein synthesis inhibitors, that's what we have seen about till now. DNA dependent RNA polymerase, DDRP inhibitor is rifampicin. What is rifampicin? Yes, anti-tubercular drug. What is RDRP inhibitor? Anyone? RNA dependent RNA polymerase inhibitor, drug which is going to be inhibiting RNA dependent RNA polymerase, a famous drug, guys. If you have spoken about this drug in 2020 or 2021, you might be the most important person throughout the world, and that drug is remdesivir. Remdesivir is a drug which is inhibiting RNA dependent RNA polymerase, DNA dependent RNA polymerase inhibited by rifampicin. So what's the answer for this question? Protein synthesis inhibitor. Which of the following anti-diabetic drug does not require dose reduction in renal failure? Simply put, which is safer in renal failure? Safer drug to be given in renal failure. This is a very recurrently asked question. Any exam if you take, we will be having one question, especially from this anti-diabetic drug, safer to be given in renal failure. Why? Because if a patient is in renal failure, I can't even give metformin. Metformin also is going to be contraindicated if the eGFR is less than 30 ml per minute. So I can't give metformin also. The drug of choice is linagliptin. Please remember this, because linagliptin is going to be excreted via bile. Bile excretion. That's why this drug can be safely administered in renal failure. This drug is safer to be administered in terms of renal failure. That is what the question is. Which does not require dose reduction in renal failure? Sitagliptin, vildagliptin, saxagliptin, dose reduced in renal failure because these are excreted via kidney. Linagliptin is not excreted via kidney. Clear? Which of the following drugs used in emergency management of asthma does not act by causing bronchodilation. This is difficult, guys, because we can't convert the question to an one-liner because lots of important points are there in this question. First of all, we have to find out which of the following drugs can be used for emergency treatment of bronchial asthma. Salbutamol, is it used? It was used, but now we don't prefer it. Ipratropium can be administered. Deriphyllin, now as per GINA guidelines, Global Initiative of Asthma 2019 guidelines, we don't use theophylline molecules here. Hydrocortisone is a steroid molecule. As per the GINA guidelines, we used to say that any acute emergency management of asthma has to be treated with a long-acting beta-2 agonistic agent with a steroid. This is the treatment option, guys. But what's the function of long-acting beta-2 agonistic agent? We have already seen that, no? Beta-2 produces what? Bronchial smooth muscle relaxation. It produces bronchodilation. So, they can be used in treatment of bronchial asthma. But what about steroid? Steroid has got anti-inflammatory property, guys. It's a purely an anti-inflammatory drug. But why are we giving it in terms of acute conditions? Why? Because previously, when the patient is on salbutamol, I told you, nowadays we don't prefer giving salbutamol. When the patient is recurrently taking salbutamol, consider this is your bronchial smooth muscle. On the surface of bronchial smooth muscle, I have 4 receptors. I have 4 receptors of bronchial smooth muscle, beta-2 receptors on the surface of bronchial smooth muscle. When you administer salbutamol, it will going to be binding with first receptor, second receptor, third and fourth receptor, and thereby it is going to be involved in production of symptoms, that is in production of bronchodilation. But on recurrent usage of salbutamol, what happens is there is going to be internalization of the individual receptors. Because of recurrent stimulation, there is going to be internalization. Because of internalization, at last there is going to be only one receptor. When you give the same dose of salbutamol, only one receptor will be stimulated, not enough bronchodilation will be seen. Patient's symptoms will not be weaned. He will come back to you with the symptoms of bronchial asthma. He will be having wheeze. So, how do we prevent that? How do we prevent this kind of internalization from happening? If we give steroid molecule, if we give a steroid molecule, it will prevent the internalization from happening. So, thereby all the receptors are expressed out and it produces more bronchodilation. Am I clear? Steroid has got 2 major mechanisms. One is anti-inflammatory property. Anti-inflammatory property. Second is it will increase beta-2 sensitivity. It increases beta-2 sensitivity. Is that clear? Now comes the next question. We'll go back to the question again. Which of the following drugs used in emergency management of asthma does not act by producing bronchodilation? Steroids are producing bronchodilation? No, right? It is not by per se producing bronchodilation. It's an anti-inflammatory drug. It increases beta-2 receptor sensitivity. That's the mechanism of steroids. Salbutamol produces bronchodilation, beta-2 receptor agonistic property. Ipratropium, the name contains trop. It's an anticholinergic agent. Cholinergics tend to produce bronchial smooth muscle constriction. Anticholinergic agents produces bronchial smooth muscle relaxation used in treatment of COPD and bronchial asthma. Deriphyllin is a drug which will produce bronchodilation because deriphyllin or theophylline per se is a phosphodiesterase 3 or 4 inhibitor, thereby increases cyclic AMP which further produces bronchodilation. Hydrocortisone is purely an anti-inflammatory agent. It is used in emergency management, but it will not produce bronchodilation. It increases the sensitivity of beta-2 receptors for this. Which of the following is the action of dopamine at low doses? Very direct question, no? Yeah. Increases renal blood flow, vasoconstriction, positive chronotropic, causes hypertension. Dopamine, we have 3 different doses of dopamine, guys. We have low dose, medium dose and high dose. Here we are talking about dopamine. As per dopamine is concerned, we have low dose, medium dose and high dose. What exactly is low dose? Low dose means less than 2 microgram per kilogram per minute dose. Medium dose is 2 to 10 microgram per kilogram per minute infusion. High dose more than 10 microgram per kilogram per minute dose. So what are the different receptors with which every individual dose of dopamine tend to act on? Yes, spelling of dopamine is wrong. It's not dopamine, it's dopamine. But why have we changed the spelling is low dose acts at dopaminergic receptors, medium dose acts at beta receptors, high dose acts at alpha receptors. Dopaminergic receptors, beta 1 receptors, alpha 1 receptors. Is that clear? If it is acting at dopaminergic or D1 receptor, what is going to happen? If it is acting at D1 receptors are there in the renal blood vessels. D1 is a GS coupled receptor. We have already seen that in general pharmacology. GS receptor produces smooth muscle relaxation. This D1 is going to be there on the renal blood vessels. So what is going to happen? Renal vasodilatation. Beautiful. It is going to be producing renal vasodilatation. When the renal blood vessels are dilated, more blood will be flowing towards the kidney, more GFR, more urine output tend to occur, which means it will produce diuresis. That's why this dose of dopamine, low dose of dopamine is used in treatment for oliguria. Used in treatment for oliguria, we can increase the urine output. Next one, beta 1 receptor. If beta 1 receptor is stimulated, we know it is there in your heart. It produces positive inotropy, positive chronotropy, positive dromotropic effect. What about alpha 1 receptors? Alpha 1, remember alpha A, B, C, D. Remember that we have A, B, C, D. Alpha 1 causes vasoconstriction, beta 2 causes vasodilatation. Alpha 1 causes vasoconstriction, beta 2 causes vasodilatation. Alpha 1 produces vasoconstriction. If the blood vessels are constricted, what will happen to the blood pressure? Increased blood pressure. This is the nature of every individual dose of dopamine which we administer in terms of a patient. With this concept in mind, we'll look back the options. Which of the following is the action of dopamine at low doses? What receptor? D1 receptor. It increases renal blood flow. Yes, that is the answer for that. We'll move towards the next options. It causes vasoconstriction. That is seen at which dose, buddy? High dose. Beautiful, beautiful. High dose. It has positive chronotropic action. Which dose? Fantastic. Medium dose. Medium dose. It causes hypertension. High dose. Why? Because alpha 1 produces vasoconstriction. BP is increased hypertension. Answer for this question is it increases renal blood flow. Which of the following antidepressant drug acts by inhibiting the reuptake of both serotonin and noradrenaline? What exactly is this concept, guys? See, what hormone or what neurotransmitter do you think is important for you to be happy? Serotonin. Fantastic. Serotonin is the one which is going to be keeping you happy, right? Even noradrenaline has got a milder effect in keeping you happy. Consider here is where your serotonergic or noradrenergic neurons. Here's where the postsynaptic terminal is. We need more amount of serotonin in the synapse. We need more amount of norepinephrine in the synapse so that it can continuously interact with the receptors. Only if it is interacting with the receptors, patients will be happy and normal. But here what has happened is, it's not been let, especially in terms of depression patients, it is not happening. Why? Because we have a vacuum pump. We have a vacuum pump on the presynaptic terminal. This vacuum pump is called a serotonin transporter and we have norepinephrine transporter. The function of that vacuum pump in pharmacological books, they will be saying that reuptake, both are same, don't need to worry. The concept of this reuptake is, or vacuum pump is, once it is getting opened, it just sucks in the serotonin back into that. It sucks in 5-HT back into that presynaptic terminal and norepinephrine, again it is going to be sucked up back into the presynaptic terminal. Which means we need serotonin and norepinephrine in the synapse, but it is not been occurring because of serotonin transport, norepinephrine transport. Simple, right? So what will be the mechanism of treatment for depression, guys? Just block the serotonin transporter and norepinephrine transporter, right? Serotonin transporter will be inhibited by selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. Norepinephrine transporter will be inhibited by, there is no separate drug which is blocking the norepinephrine transporter reuptake. We have cocaine also will produce the similar mechanism. But here we have two drugs, or we have one drug which tend to be inhibiting both serotonin and norepinephrine reuptake. Those drugs are called as serotonin norepinephrine reuptake inhibitor. Serotonin norepinephrine reuptake inhibitor. SSRIs includes citalopram, paroxetine and many other drugs. SNRI, currently which we use in practice is escitalopram, we use it in practice. SNRI, we have two major drugs, venlafaxine, duloxetine. We have venlafaxine, duloxetine. These are SNRI drugs. Simply, what is the one-liner of this question? Which of the following is an SNRI? Fluoxetine is an SSRI. Venlafaxine is an SNRI. Beautiful. The answer is going to be venlafaxine. Phenelzine is actually a Phenelzine is not an SNRI. It's a tricyclic antidepressant. Nortriptyline again is a tricyclic antidepressant. What exactly is this tricyclic antidepressant? This tricyclic antidepressant is a drug which tend to block not only serotonin transporter, also tend to inhibit alpha-1 receptors, muscarinic M1 receptors, histaminergic H1 receptors also. That's why patients tend to have lots of adverse drug reactions of tricyclic antidepressants. We don't prefer giving TCA. Instead, we opt for SSRI. One important point. The second point is TCAs tend to have narrow therapeutic index. There is more chances of toxicity symptoms. That's why we don't prefer giving TCA. We prefer giving SSRI alone. If the patient is not responding properly with SSRI, we can prefer giving SNRI. Which of the following antimicrobials is contraindicated in a patient with seizure disorder? Wow. Antimicrobials and epilepsy, we have combined two different topics together. Please remember, guys, one important antibiotic which tend to be inducing seizures is imipenem, guys. What exactly is imipenem? Imipenem belongs to a class called as beta-lactam antibiotics. Yes, it belongs to beta-lactam antibiotic. What are the beta-lactam antibiotics? We have penicillin, cephalosporin, carbapenem, monobactam. Out of this carbapenem is nothing but your imipenem. As per imipenem is concerned, please remember these basic points. Point number 1, this drug belongs to carbapenem group and this drug is an extremely short-acting agent. Point number 1. Why is it a short-acting agent? Because this drug is a peptide molecule. Imipenem is a peptide molecule. Point number 3, that's why we never give imipenem as monotherapy. We give imipenem along with cilastatin. Cilastatin, if the drug name is ending with statin, it's an anti-hyperlipidemic. No, it's not an anti-hyperlipidemic agent. Cilastatin is actually a dehydropeptidase inhibitor. It's a DHP inhibitor. What is dehydropeptidase? You know why imipenem is short-acting? Because it's a peptide molecule. Why peptide molecules are short-acting? Because it is broken down by peptidase enzyme. What's the peptidase enzyme here? Dehydropeptidase. If I inhibit that, I can increase the half-life of imipenem. And the last and most important one is seizures. Imipenem tend to produce extreme adverse effect of seizures. That's the reason why instead of opting for imipenem, we choose meropenem or ertapenem, which comes under the same class. Is that clear? So the answer for this question is going to be imipenem. Please remember that. What about the other drugs which we currently have? Ampicillin is actually a beta-lactam antibiotic, penicillin group. It produces more diarrhea. Ampicillin causes more diarrhea. Moxifloxacin. What is moxifloxacin? Floxacin means it's a DNA gyrase. Remember, fluoroquinolones. It's a DNA gyrase inhibitor. Moxifloxacin belongs to fluoroquinolone groups. Cefixime, we know cefixime. What's cefixime? Third generation cephalosporin. This is a cephalosporin. All these three drugs are not going to be producing seizures, only imipenem is associated with seizure production. Drug of choice for treatment of digoxin-induced ventricular arrhythmia is digoxin-induced ventricular arrhythmia. Just close your eyes. You are not converting into one-liner, guys. Already the question is in one-liner. We are going to put up the answer. You can just immediately close your eyes and go for lignocaine. That is the answer for this question. Digoxin-induced ventricular arrhythmia, the answer is going to be lignocaine. Not only that, any type of ventricular arrhythmia, the drug of choice is going to be lignocaine. Post-MI ventricular arrhythmia treatment, lignocaine. Digoxin toxicity, overdose, we use digibind. When digoxin is given at overdose, we can use digibind. Digibind is actually a polyclonal antibody, not monoclonal, polyclonal antibody. Atropine cannot be used in this condition, guys, digoxin-induced ventricular arrhythmia. What is digoxin actually? Digoxin is a drug which is used for congestive cardiac failure and atrial fibrillation. Treatment of congestive cardiac failure and atrial fibrillation. Amiodarone is a potassium channel blocker, which is also an anti-arrhythmic agent, class 3 anti-arrhythmic agent. Procainamide belongs to class 1 anti-arrhythmic agent. It's also a sodium channel blocker. A female patient presented with pain and redness in grade 2. Serum uric acid level is 9.6 mg per deciliter, more than 7. Apart from prescribing analgesics for relieving pain, the physician prescribed a drug which can decrease the formation of uric acid. Which of the following enzyme is likely to be inhibited by this drug? Simply put, answer is very much simpler. What is the one-liner here? Which of the following enzymes is involved in synthesis of uric acid? That's what the question is. We have converted pharmacology question or medicine question towards what? A biochemistry question. We have converted them. We have converted the subject itself. Synthesis of uric acid, we know that, no? We have hypoxanthine converted to xanthin, converted to uric acid. All these things are characterized by the enzyme xanthin oxidase enzyme. So, this xanthin oxidase, if it is getting inhibited, uric acid synthesis will not occur. Why are we preventing that uric acid synthesis? Because hypoxanthine is a water-soluble metabolite. We can easily dissolve in urine and throw it out from the body. Xanthin also is a water-soluble metabolite, dissolved in urine, thrown out from the body. Uric acid is water-insoluble metabolite. I cannot dissolve the uric acid in water and also in blood. That's the reason why the patient lands up in gout or hyperuricemia symptoms. So, how can it be inhibited, guys? We have allopurinol, the famous drug. Allopurinol and its active metabolite oxypurinol, and the drug which we currently use commonly in practice, febuxostat. All these three drugs are xanthine oxidase inhibitors. These drugs will inhibit xanthine oxidase, and that's what they have given for this patient, because they have given a drug which can decrease the formation of uric acid. Am I clear? So, the answer for this question is going to be xanthine oxidase. That is the answer for this question. Is that clear? But this gout or symptomatic therapy is not seen only, is not seen with other mammals, guys. It is seen only in humans. It is not seen with other mammals. Why is it? Because the other mammals convert uric acid to allantoin with the help of an enzyme called as uricase. This allantoin in turn is a water-soluble metabolite. So, what we do is, we take up the uricase enzyme from the other mammals, we do recombinant DNA, and we convert the uricase in such a way that it is not producing hypersensitive reactions to the human body, and we administer it to the human beings, and we have derived, what are the drug names? Pegloticase, rasburicase, pegloticase, rasburicase. These are the uricase analog agents which can be used in treatment for gout. That's it, guys. We have completed the discussion of previous year questions. Lots of questions were there. I have removed all the repeated areas. I have comprised all the questions in a single video. I hope it will be useful for you. meet you in one more session as soon as possible. Bye.